Thank you for joining us for this MD Magazine peer exchange on therapeutic strategies in chronic obstructive pulmonary disease. COPD is an increasingly common diagnosis associated with significant morbidity and mortality in the United States and worldwide. The cornerstone of COPD management includes an emphasis on lifestyle modifications as well as therapeutic interventions to increase survival and improve quality of life. I am pleased to be joined today by a panel of experts in pulmonary disease to review the current treatment landscape as well as to discuss evolving treatment strategies in COPD. I'm Dr. Peter Salgo, by the way. I'm a professor of medicine and anesthesiology at Columbia University College of Physicians and Surgeons and an associate director of surgical intensive care at New York Presbyterian Hospital. So, joining me for this discussion today are Dr. Jim Donohue, a professor of medicine and former chief of the Division of Pulmonary and Critical Care Medicine at the University of North Carolina at Chapel Hill. Dr. Fernando Martinez, chief of the Pulmonary and Critical Care Medicine Division at Weill Cornell Medicine and New York Presbyterian Weill Cornell Medical Center. Dr. Byron Thomashow, professor of medicine at Columbia University Medical Center, medical director for the Joanne Le Bon Center for Chest Disease at New York Presbyterian Hospital, and chairman of the board of the COPD Foundation. And Dr. Frank Sciurba, visiting professor of medicine and education director for the Emphysema COPD Research Center of the Division of Pulmonary and Critical Care Medicine at the University of Pittsburgh. Thank you, all of you, for joining us. Your titles are long enough. I think we're done with this entire broadcast. That being said, we have a lot to cover, so why don't we get going? I want to discuss right away COPD in the 10,000-foot view. I don't think people really understand how common this is. When I was in medical school, COPD was something some people got, but it's much more common than that.
Yeah, over 16 million Americans have been diagnosed with COPD now. Evidence suggests another 12 to 14 million probably have the disease but haven't been diagnosed. It's the third leading cause of death in this country, the second leading cause of disability, and the cost of caring for COPD in this country now stands at over $50 billion a year. But despite those staggering statistics, and I think it's important to come out during the whole conversation, it's important to stress that COPD is almost always preventable and almost always treatable, although I think most of us would agree we need better treatments and ultimately we need to figure out a way to get some cures.
I want to go back for a minute because some of those numbers are not just staggering, they're shocking in the sense that I don't think doctors appreciate them. How can this be this common, have this much of an impact on this country, and most doctors don't understand and don't know about that? Anybody got an idea?
Well, it's not high on the doctor's differential diagnosis, and that's what the work of the foundation, the NIH, everyone trying to increase awareness of it. And in fact, if many of the patients now that we're seeing around the world haven't even smoked, it's biomass, particularly in women. I was visiting Mexico and then last month in India. And so biomass fuel, there are many different causes, but still in the United States, it's cigarette smoking. We really have to increase public awareness.
Now, there's a number that I saw that about 1 out of every 4 people with COPD never smoked. Now, does this mean that it's biomass, or is it that it's etiologically indeterminate? We just don't know.
In the United States, the number of smokers is, in the high 80s, approaching 90%.
That still gives you 20%.
Right, but in worldwide, though, like in India, half the women were biomass and never smoked. So it's just something to be aware of. As we're a nation of immigrants, more and more folks are coming in. It's particularly women who have had, single room dwellings with cook stoves that are not vented.
I got it.
But I do think that it's important. I think that Jim's point is worth stressing because I think most of us in the field have struggled for years with 2 issues. One is the blame issue. And I think that has colored this whole disease state for reasons I think most of us don't understand because you have similar risks with cardiac disease and vascular disease. But the blame issue is important, and I think that has hindered our progress. And I also think that for the longest time there's been a nihilism that existed among our colleagues, whether on the pulmonary side or the primary care side, that there just wasn't much that they could do. And you put those 2 issues together, and I think that those are some of the things we've been trying to move against.
I think Byron has summarized very succinctly the answer to your question.
He's good at that, by the way.
Those, I think, are the 2 key reasons that we have these staggering numbers, and people are surprised when they hear it.
I have a particular theory about why there's this blame game with COPD and not with heart disease and vascular disease, and it's that you can see it. In other words, people with COPD are obviously struggling, right? You can have heart disease because, name your radiologic agent you'd like, diet, exercise, smoking, but your ticker can't be seen until you have an MI. Here, folks are struggling every second. It's easy to point a finger, you know? And what's the other thing? The other thing is it's expensive, right? You send somebody home, what percent, and I know this number, what percent of the people sent out after a hospital admission for COPD bounce back within 30 days? I heard it was 20%.
At least 20%.
No.
Yeah, it's a major driver of healthcare costs. I mean, it's incredible when you actually see those numbers and you actually contextualize it and put it within the context of some of the other diseases. Peter, it really is an amazing impact that it has.
The other thing is the perception that it's a simple disease and that they know everything about it.
Wait, you mean it's not?
The number of patients admitted to the hospital where they don't consult pulmonary, you wouldn't think of doing that with an advanced cardiac disease. And so I think that's the purpose of this group here right now, is to show you there's a lot going on, and we're going to show it to you.
I want to come back
A lot
to
of good
that.
things going on. A lot
of good things. Yeah.
Just a quick comment on the balkanization of healthcare, where people come into the hospital with COPD, and maybe in the emergency room they're seen by the emergency room physician or on the ward by a hospitalist, and those physicians do a great job, but they don't want to assume long-term care. That 30-day relapse has a lot to do with the medicines people are sent home on, the frequency of follow-up, and there's a huge penalty for Medicare.
I was about to say, that's expensive, right?
Right,
Because if you come back within 30 days,
That's right.
that admission's not covered.
So that's the good news, because that means the heavy hands of the health industry, the hospitals and what have you, who have big bucks, are investing now in this topic.